Okay, we're going to take a look at who to screen, how to treat, who we're going to treat, how long to treat, and the problems with therapy. And finally, romosozumab is here. After about 10 years of studies and waiting, it's finally on the market. Let's take a quick look at the definition of osteoporosis. I always like to start with that. Postmenopausal osteoporosis is really excessive osteoclast or bone destroying mediated problems with the bone. The mineral to matrix ratio is normal. And when you're treating people with osteoporosis, you need to make sure they don't have any other diseases, principally osteomalacia, that makes the mineral to matrix ratio not normal. If it's not normal, you're not going to get good results with your bisphosphonate, with your denosumab, with your bone stimulators. Has to be normal. You have to have the calcium and vitamin D in place. Now, the bisphosphonates, particularly, and denosumab or Prolia, reestablish vertical trabeculation. You can see what happens here. You got holes in the bones. It's mainly loss of the vertical trabeculi, and you reestablish those with the medications we're going to use. But the bisphosphonates do that by shutting off bone destruction. They inhibit osteoclasts. But at the same time, they stay in the bone for long periods of time, so they also, after about 5 or 6 years, begin to inhibit the osteoblasts, or bone-building cells. And that's why we have atraumatic femoral fractures. It's why we have osteonecrosis of the jaw. So some of the side effects that are very rare but significantly horrible for the patient result from the fact that bisphosphonates stay in bone, and eventually, if you inhibit bone destruction long enough and consistently enough, you inhibit bone building. Now, denosumab doesn't stay in the bone for very long, so it doesn't inhibit bone building. But, very important take-home point, when you stop denosumab or Prolia, you lose the bone you gained. The bone stimulators, likewise, build a lot of bone, but they don't stay in the bone. So when you stop them, you lose the bone you've gained. So you have to do something to kind of cement that bone in place. And so that's the summary of today. And we'll take a look as we go along a little bit more about bone resorption inhibition and bone stimulation. Okay, who to screen? This really hasn't changed from last year. Again, women age 65 or older, and postmenopausal women at risk for fracture. Men, I know it's a women's conference, but occasionally some of you probably see a man in your practice, and men 70 or older. People who are at risk, and these guidelines are changing. Rheumatoid arthritis patients, patients on steroids, particularly the last year they added malabsorption. So anybody who has GI problems, who has malabsorption, who has an eating disorder is going to be at risk and needs to be screened. People with a fragility fracture after age 50, those people have osteoporosis, but you can screen them to get a baseline so you know if your therapy is working. Vertebral imaging. Well, you can get an x-ray of the spine, and if your patient particularly is over the age of about 65 and begins to have problems with discomfort, or their DEXA scan T-score is -2.5, you might consider vertebral imaging, because some vertebral fractures are painless. Most of them, however, are very uncomfortable. So again, vertebral imaging is something you can do as an extra if you're worried about the patient, because the spine is frequently the first place where osteoporosis is noted. Okay, how to screen? Well, there's no discussion about that. You screen with the DEXA scan. The DEXA scan makes the diagnosis for you, and I would suggest you look at the picture. How many of you have a PACS, have access to PACS? Most people who have electronic records now have access to PACS. So you can actually read your own DEXA scan. It's not rocket science, and the diagnosis is pretty much printed on the page. So the other thing your DEXA scan does is monitor the efficacy of therapy. And Medicare now only pays every 2 years for people to have DEXA scans, but that's okay. The DEXA has about a 5% precision rate. So essentially, every 2 years is adequate. But when you do that, Don't compare the T-scores. Compare the bone mineral densities. That's what you're looking at. The T-score is a surrogate marker. So again, monitoring effectiveness every 2 years, get a bone mineral density. Look at the bone mineral density. It should be on the report. And not only that, the report should tell you whether or not your patient has had a significant change in their bone mineral density. If it doesn't, find another place to do your DEXA scans. If we take a look at the DEXA scan, this is the spine. It should be straight up and down. And this is the young adult mean. And the T-score is the number of big blocks, which are standard deviations, above or below the young adult mean. So here we have someone who has excellent bones here. But if you look at this picture, it's easy. The osteopenic people are going to be kind of yellow and orange, and the osteoporotic people will essentially always be red. So there you go. It doesn't take much to read your DEXA scan. So again, the T-score is the number of standard deviations above or below the young adult mean. The Z-score is compared to the age-matched mean. As we go along this morning and talk about eating disorders, the Z-score tells us about osteopenia, osteoporosis in people under the age of 50, where most of our eating disorders patients fall. Now many of our patients look like this. And so if you have severe scoliosis, if you have actually more than 15 degrees of scoliosis, then you're not going to be able to tell very much here. And this person has some compression fractures. And so you can say, well, okay, I've got the diagnosis here. The T-score is minus 4.8, minus 2.5 is osteoporosis. This person has osteoporosis. That's great. But in 2 years, when you look at this person, do you think you're going to be able to tell a change in this? It's a dead giveaway when the boxes are not square. So the boxes are not rectangles, rather. So here's a nice rectangular box. And here, you can't even figure. Those are triangles. When your boxes are triangles, things aren't going well. Okay. So in a lot of people, we're going to use the hip and not the spine. And if you look at the hip, it has a standard position. It is not so affected by arthritis. It seldom has the deformities the spine has. And so it's the best place to look, particularly in your patients over the age of 60. And so you have a standard position here. It's supposed to be a 45-degree angle. The femur is perpendicular. This is the lesser trochanter. And most important, the femoral neck box is where? It's on the femoral neck. And you say, well, obviously not always. Here's a picture. These are 2 pictures I took when our X-ray department wasn't looking, and so I just sort of scarfed them up for a slide. But the most common problem here is that the femoral neck box is not on the femoral neck. You're supposed to be comparing bone to soft tissue to soft tissue. Here you're comparing soft tissue to bone, to bone, and that makes the T-score much lower. So just take a quick look at that picture. Femoral neck box is in the right place, you're probably going to have a good DEXA scan, and you can interpret it yourself or just read the report. Okay, remember the World Health Organization classifies osteoporosis, and they tell us that a T-score down to -1 is normal, -1 to -2.5 is osteopenia, and -2.5 and below is osteoporosis. But they don't tell us what's causing the osteoporosis. They don't tell us the disease. So you could have a vitamin D deficiency, have osteomalacia, have poor mineralization, and still have a T-score of -2.6. And we'd say, well, you have osteoporosis. The osteoporosis diagnosis is related to fracture, but you don't really know. You could have a lot of other diseases in there, the most common one being osteomalacia. In addition to that, it doesn't measure bone strength, and it tells you nothing about the bone matrix. Remember, in diabetes, the bone matrix is the problem. It's glycosylated. Remember hemoglobin A1C? Lots of things are glycosylated. So in the patient with diabetes, the bone matrix is glycosylated. It doesn't fit together as well. It doesn't mineralize as well. And that's why the patient with diabetes type 2 particularly is more likely to have osteoporosis. So because you're not going to diagnose with the DEXA scan. So the DEXA isn't perfect, but it's what we have. Now, let's take a look at who to treat. Our goal here is to prevent fractures in people who are at risk. Our goal is not to treat everybody with osteopenia to see if we can make their bone better. We want to find the high-risk people and treat them. As we talked about, the bisphosphonates, The denosumab, the bone stimulators are not without problems, and particularly long-term problems in some cases. So we really need to choose our patients carefully. And we want to treat all the patients with osteoporosis, T-score of -2.5. But how about the people who have osteopenia? How are we going to treat them? We're going to look at their risk factors, right? And when we look at their risk factors, we find out that the people with osteoporosis have a horrendous fracture rate. Look at the fracture rate in yellow here. And see, these are people with osteopenia. Then we go up to osteoporosis. Look at the change in the fracture rate. And that's how they decided on -2.5 for osteoporosis. You're going to change the fracture rate here a lot. But if you look at the number of fractures in blue, the number of fractures, just most of the fractures occur in the osteopenic population. So the fracture rate in the osteoporotic is high, but the number of fractures in the population is higher in the osteopenic people just because there is such a large number of them. So which one of these osteopenic people should we treat? And how many of you are using fracs? Good, excellent. So almost all of you are using fracs, so we won't spend very much time on it. Again, fracs is an algorithm that has been used. It's a worldwide algorithm that was developed by the World Health Organization and Dr. John Canis, and it helps you use common risk factors to predict fracture risk in your patients. It's really very good, particularly if your patient is age 60 or more. Particularly if you can add a DEXA scan to this, it gives you a very good prediction of who is going to fracture. So again, does it have problems? Yes, and the biggest problem is it doesn't address falls. Mrs. Jones has a T-score of -4.8. You think, oh my goodness, she's going to cough and fracture her hip. Or she'll cough and fracture her ribs, but she's not going to fracture her femur unless she falls down, right? So addressing falls is one of the big problems, and we don't exactly know how to do that yet. But again, all algorithms have difficulties, and if your patient has type 2 diabetes, they have now looked at what to do in that area. So patient has type 2 diabetes, you tick off the rheumatoid arthritis box because that has about the same weight as type 2 diabetes. See, type 2 diabetes is a fairly decent risk factor for osteoporosis, as much as rheumatoid arthritis. They're both inflammatory diseases, and sleep apnea is also an inflammatory disease. We don't quite have the adjustment for that in fracs, but they're looking at it at the moment. So again, if your patient has type 2 diabetes, you can tick off the rheumatoid arthritis box, or if it's already used, you can subtract 0.5 from the T-score and then put the T-score into the T-score box in the fracs and use that for your calculation. Okay, who to treat? We're going to treat these people no matter what their DEXA scan shows, right? Okay, this is the updated NOF classification of who to treat. Anybody who is age 50 with a hip or vertebral fragility fracture, GYN got to me, fragility fracture, you're going to treat. They have osteoporosis. Any other prior fracture and a low bone mass. So if you had a prior fragility fracture and your T-score is -1 or lower, I'm going to treat you. You have osteoporosis. And again, T-score of -2.5, we said, low bone mass and other causes of risk. Steroids, malabsorption, T-score of less than -1, you're going to treat that patient on steroids. T-score of -1, you're going to treat with malabsorption. So again, you're going to treat those folks that you know are high risk. And finally, Medicare has used our fracs calculation, and you have to have a 10-year major osteoporotic related fracture probability of greater than 20% or equal to 20%, and a hip fracture probability greater than or equal to 3%. We're going to treat you. So that's how you use the fracs. You use the 10-year probability of fracture in the hip and other major osteoporotic fractures. Okay, how to treat? Let's take a look at the simple things, calcium, vitamin D, and exercise, and the Endocrine Society guidelines that came out in May of 2019 have changed our perspective on that just a little bit. Calcium, how much? Well, pregnant women, 1,300 milligrams. Men and women that are not pregnant, 1,200 milligrams a day if they have normal renal function. As your patient gets to stage 3 or 4 CKD, they may not be able to tolerate 1,200 milligrams. You probably ought to, as they get into stage 3, move them down to about 1,000 milligrams a day. Stage 4 and 5, I negotiate with a nephrologist. He or she would like them to have lower doses of calcium. I would like them to have higher doses of calcium. So we usually pick something in the middle and compromise. But you don't want to give those people with stage 4 renal disease 1,200 milligrams of calcium because they simply can't clear it. So again, normal renal function, try to get in 1,200 milligrams a day. The U.S. Preventive Health Task Force says, well, if you don't have bone disease and you're premenopausal particularly, or postmenopausal even, then I don't have to give you calcium supplements. That's okay. When you're using calcium supplements in the postmenopausal woman who is not osteoporotic, you're on a little shaky ground. For osteoporosis, we're using calcium and vitamin D for therapy. So when you're treating your postmenopausal woman that's at high risk of fracture, calcium and vitamin D are very important. And calcium and vitamin D, according to the new endocrinology review of the literature, has shown to decrease the risk of hip and major osteoporotic fractures. Didn't quite reach significance to prevent spinal fractures, interestingly enough. So calcium and vitamin D, good for you. Dietary calcium is best. Now, the question is, does taking calcium cause it to sit in your arteries? Apparently not. And these are 3 studies. These are all observational studies. They're large. And the National Institutes of Health Diet study has over 200,000 people in it, and they've been followed for almost 10 years. So it would appear that there's no association with cardiovascular death, stroke, myocardial infarction, or calcification of your coronary arteries by taking 1,000 to 1,200 milligrams of calcium a day, even if you have some renal insufficiency, even if you have existing coronary artery disease. So yes, your patients can feel safe taking this. Dietary calcium is best. And hopefully the end of the calcium story, and you talked about the people in JNC8 and how they worked forever, to get their results, and Dr. Fetty talked about that yesterday. These people spent an incredible amount of time. They looked at every single study, did meta-analysis of every single study they could find that addressed cardiovascular events and all-cause mortality in women over 60, and they looked at calcium intake in all of these studies. And that meant the control groups in all of the big studies that they did to get osteoporosis drugs approved, 1966 to 2013. That was just a lifetime work practically. But they did this, and they suggest there's no increase in cardiovascular events on 1,000 to 1,200 milligrams of calcium supplements. We don't know about 1,500. We don't know about 2,000. So you don't want your patients on excess calcium. We do know that 1,500 milligrams and above doesn't decrease the fracture risk any more than 1,000 to 2,000 milligrams a day. How much D? Again, there's a big controversy about that. The NOF says 1,000 to 1,500 international units a day. You shouldn't have more than 4,000 a day. And people come into your office and you say, well, how much calcium and vitamin D are you taking, Mrs. Schmadlap? And she says, oh, I don't know, but I brought my bag of supplements. And you say, God, I have 20 minutes to see you, Mrs. Schmadlap. I can't even open this bag and put them all on the desk in 20 minutes. So my homework for these people is to go home, find out how much calcium and vitamin D you're taking. Most people are undertaking calcium and overtaking vitamin D in my practice, and probably in yours as well. But remember, vitamin D also decreases the risk of non-vertebral fracture. So again, it's going to be wrist, ankle, hip. Now, How much vitamin D? Where should your 25D be? Remember, we're measuring 25-hydroxyvitamin D because it's a long-lived metabolite, so it tells us about our vitamin D stores. And there's a controversy, of course. Endocrinologists argue about the strangest things, about where you should be in this interim. Well, they got rid of insufficiency. There you go. So people suggest that if you're going to treat a patient with bisphosphonate, you ought to have the vitamin D level above 25. Easy to remember. 25-hydroxy-D should be 25 or above before you treat with a bisphosphonate. If your D level is less than 25, you can get, achy, muscle cramps, bone pain, because you have osteomalacia. When I treat osteomalacia with bisphosphonates, you get bone pain. So again, you'd like those people to have a 25D of 20 nanograms per mil at the lowest, and most of us like 25. Ideally, when you're treating osteoporosis in the long haul, you want them between 30 and 40. But you say, she came in and I just talked her into using some medicine, and the vitamin D level is 25. Go for it. Get her fixed. But you could start at 25. Vitamin D level is 20. That's a little risky. About 3 to 5% of people get bone pain. If you're under 10, virtually everybody gets some bone pain when you treat them with bisphosphonate. So don't go there. Ideal, probably someplace between 30 and 40, actually. There's some controversy about that. Okay, who to screen for vitamin D deficiency? Anybody with a hip or non-union fracture, hip fracture of any kind or non-union fracture. We found that when we screened our patients with hip fractures who came in, I was just looking at our orthopedic data last night, and 25 of the first 50 patients who came in had vitamin D levels of less than 10. Oh my goodness, terrible vitamin D deficiency. So you're going to treat those people because they had a fragility fracture of the hip. And so you've got to fix their vitamin D. So be sure you check that. Again, young patients with a fracture in any site. If you have a teenager that has a fracture, if you have a child that isn't, riding something or falling out of a tree, if you have a child that trips and falls and breaks something, that child has abnormal bones. So you want to take a look at them. Pregnant patients, you'd like to really screen them to make sure their 25D is adequate. Malabsorption, particularly gastric bypass. Something like 85% of the people with gastric bypass over 2 years old have vitamin D deficiency. That's significant. Why is that, you think? They don't take their vitamin D. So again, as people get, first year, they're really good. They take everything. And then as time goes by with their gastric bypass and they're losing a fair amount of weight and they feel better and they look better, they begin to stop taking their calcium, their vitamin D, and so on. So especially after a couple of years, the gastric bypass folks. And anybody with a rapid bone turnover state, such as hyperparathyroidism, about 75% of people have a vitamin D insufficiency, a low vitamin D of under 30. Okay, replacing D. If your goal is 30, you're just going to get them there, then you can just use 1,000 IUs a day if they're in the 16 to 20 range. If they have actual vitamin D deficiency, you're going to get down there and you're going to use those old, large, squishy 50,000 international unit D2 tablets once a week for 8 weeks. That was discovered in 1998 by Michael Hollick, who was also the discoverer of 125-dihydroxyvitamin D. So again, it's old data, but it still works. You say, I want to be more modern. Okay, use D3, which is a little more potent and is over the counter, 4,000 IUs a day. If your patient has very significant vitamin D deficiency, then it's going to be fairly costly for them to buy D3 over the counter in enough amounts to actually fix their vitamin D. So probably best to use the 50,000 international units of D2. It's slightly less potent, but paid for by the vast majority of insurance companies. And I find myself doing more and more things that are paid for by the vast majority of insurance companies. Exercise. Yes, exercise helps your bones. But people say to me, okay, that's it. I'm just going to use the natural way, the calcium, the vitamin D. And I say, fine, that helps you with non-vertebral fractures. And exercise, I'm going to build my bones with exercise. No, you aren't. I'm sorry. If you're a teenage tennis player, yes, you get more bone mass in your dominant arm where you're swinging the racket. If you're Sally Joe, who is 75 years old, no way. You can exercise. You're not going to get a significant amount of bone mineral density. However, take a look at this. This is a randomized prospective controlled study to see if targeted exercise and D reduced falls. This is 70 to 80-year-old women, okay? They had 4 groups. They had the exercise with D, the exercise no D, no exercise plus D, and no exercise and no D. And they looked at their endpoint. Their primary endpoint was falls, but they also looked at injury in those falls. They looked at falls with injurious fractures, which was falls with fragility fractures, basically. And look what they found. My husband says that women fall just because they're clumsy. I think they fall because they're so sensitive, they're always looking out for other people, and they trip over things. But look at the falls. No difference. There were quite a few falls here, but there was no difference in the fall rate in any of those groups. So vitamin D doesn't keep you from falling down. Watching where you're going keeps you from falling down. I tell it to my patients every day. Injuries, but look at the injurious falls. There were statistically significantly fewer injurious falls resulting in fractures in the people who exercised. D didn't matter. It was the people who exercised. And the bone mineral density decline in the femoral neck was lower in the people who exercised. What was their targeted exercise? They walked around the block. Actually, they walked in the gym, but they walked. It wasn't that they lifted weights or did all kinds of strength training. They did some strength training for the lower proximal musculature, but mainly they just did walking. Okay, how to treat. Before you treat people, we need to know that the calcium is normal, the 25D is normal, and the creatinine. We need to know what the creatinine was, because if your renal disease is higher than, if your stage is higher than 3A, you may not be treating osteoporosis. You may be treating only renal bone disease, and bisphosphonates don't work as well as some of the other things we can use to treat renal bone disease. So you want to make sure they have osteoporosis by checking that estimated glomerular filtration rate, and they don't have stage 4 disease and have chronic kidney metabolic bone disease. You want to know the calcium's normal, and you want to fix the 25-hydroxyvitamin D. Okay, having done that, again, approved medications in order of efficacy. And this is from the Endocrine Society May 2019 guidelines. They say that, again, as we said, anti-resorptive agents like bisphosphonates, denosumab, raloxifene, calcitonin act on the osteoclasts. And the efficacy, bisphosphonates and denosumab are essentially equal. Raloxifene doesn't decrease the risk of hip fractures, does increase the risk of clotting, does decrease the risk of estrogen receptor positive breast cancer. So I think you have to weigh all those factors. Calcitonin, we'll talk about calcitonin in a second, should be wiped off your armamentarium. We have anabolic agents that actually stimulate the osteoblasts. And now we have 3 of those. We've had 2 of them that are PTH analogs, and now we have romosozumab that we're going to talk about at the end. There's an FDA warning because calcitonin increases the risk of liver cancer significantly. So get rid of it. Now, raloxifene, again, is probably your 3rd choice. How many are using raloxifene? Not very many people. And it's certainly, if you can't use a bisphosphonate, you can't use denosumab, it's a reasonable choice. Alendronate is the most commonly used agent. And alendronate, remember, used to be called Fosamax. It is a potent bisphosphonate, and it's approved for every type of osteoporosis. It has a long life in the bone, and so it is most commonly associated with atraumatic fractures and osteonecrosis of the jaw. So it has side effects. You have to be careful of it. It's a very potent bisphosphonate. And limitations of use now, they say, we don't know how long you should use this. We know it's safe to use it for 3 to 5 years in a row. And we know that after that, it's probably going to stay in the bone for at least another 3 years, if not 5 years. So after 5 years, you may have 10 years of bone protection when you use alendronate. So it's a very good drug. So don't avoid it. Risedronate and abandronate are also bisphosphonates. Risedronate only stays in the bone for a year. So if you have someone that you want it in and out of the bone, risedronate's the one for you. And abandronate is not popular anymore. It's generic, but unfortunately it doesn't decrease the risk of hip fracture. Their data was insufficient for that. Zoledronic acid is our most potent bisphosphonate. It used to be called reclassed. Now it is generic, and it's approved for virtually everything. It's IV once a year, 15 minutes. For your patients who just don't want to be bothered with this, I've got osteoporosis, but you got to fix it quickly. Calcium, vitamin D, and the zoledronic acid once a year. Calcium and vitamin D have to be taken consistently, but zoledronic acid is only once a year. Have to be very careful they have adequate creatinine clearance. If it stays in the kidney and doesn't pass on through rapidly, it can cause acute renal injury. But a creatinine clearance of 40, we have that cutoff in our office, is very reasonable. You don't get acute kidney problems with it. You want the patient to be well hydrated, and they have to be taking their calcium. This decreases calcium. Those of you who treat hypercalcemia in the hospital, what do you use? You use a zoledronic acid infusion. So again, lowers calcium very significantly. Have to be taking your calcium, or you can have seizures. You don't want seizures in your office. It's so tacky. Also, you need to make sure your 25D level is reasonable. It really has to be 25, or you can get very significant bone pain with this. It's generic, but it's still expensive. It's about $1,100 a year. But Medicare pays for it in its entirety, as it's under Part B, because it's given in your office. Okay. Now, how about the serious side effects of these medicines we've just been discussing? Atraumatic subtrochanteric fractures and osteonecrosis of the jaw. You know how you get to be certified as an endocrinologist? At 7:30 in the morning, you can say atraumatic subtrochanteric fractures without stumbling over yourself. Okay, how long to treat? Well, you know, bisphosphonates are a hard act to follow because they're very effective. Millions of people have been using them. There's a 90% responder rate and a 50% decrease in hip fracture and about a 70% absolute decrease in the risk of spinal fractures. They work in 9 to 12 months to prevent fractures. Amazing drugs, and we've been using them now for a long time. But they're safe for 5 years, and I would certainly say oral safe for 5 years, IV safe for 3 years. Don't be afraid to use these drugs. In the last 5 years, the use of bisphosphonates has markedly diminished because people are afraid of these problems that we're going to talk about. But they're very safe medications. The risk of hip fracture in the United States is 750 to 830 per 100,000, and the risk of atypical fracture, atypical subtrochanteric femoral fracture, after 5 years of use, 16 per 100,000. After 9 years of continuous use, 113 per 100,000. Now this is a retrospective study. It's a look at the Kaiser Permanente data, and mainly it's looking at alendronate. So it's looking at what used to be Fosamax. That's the main one that's being used in the United States. But look at that. It's relatively low compared to the 50% decrease in hip fractures that we get with these medications. And your patients won't get these fractures if you pay attention to them and look at and just look at what you're doing. We used to say, well, gosh, who gets suppression? Is it Sally Joe, who's thin? Is it Mary Jean, who had lower T-scores? Well, the FDA said to the zoledronic acid people, excuse me, we have bone markers. Tell us who gets suppression. Let's figure out who's going to get suppression after 3 years or 5 years on a bisphosphonate. And they looked, and after 3 years on zoledronic acid, who had suppression? Everybody did. The degree of suppression was different, okay, but the reduction in bone formation on average was about 29%. So everybody had it. It was not just somebody who was at higher risk. Now we know that although everybody has suppression of bone building to an extent, there are high-risk people who are more likely to have these femoral fractures. And so we can identify them. And there are important clues to identifying who, with bone suppression, is going to have the subtrochanteric fracture. It has a prodrome. 70% of people who have these fractures have pain in their femurs. You say, oh, my patients all have osteoarthritis of the hip. How am I going to know? It's not that pain. It's pain right up and down the femurs. And not only that, they have comorbid conditions, vitamin D deficiency, diabetes, rheumatoid arthritis. And again, the drug holiday, if you take your patients off for a couple of years, decreases that risk markedly. Bone turnover starts again in about 2 to 4 years in most patients. So you can alter that problem by finding the people with the prodrome, by looking at D deficiency, by making sure you have a drug holiday when you can, and also, of course, use of bisphosphonates and glucocorticoids increases the risk of that type of fracture. Bilateral fractures may well occur, and usually they have delayed healing. But you can see on the x-ray when your patient is about to have them. They're stress fractures. And the latest report from the Bone and Mineral Society says what you can do is get an x-ray. Just write bisphosphonate on that x-ray in the little box under comments, and the radiologist will know to look for these changes in the periosteum. And even the endocrinologist can see that change right there. If you have a DEXA scanner that can go down that far, and a lot of DEXA scanners have that software, the DEXA scan can actually see the changes and can tell you the patient's at risk for an atraumatic fracture. And what happens if you don't do something about that is that you fracture right along that stress line. So it's a stress fracture. You can see it early. It has symptoms. We shouldn't miss those. And we've had a number of people who come in with the prodrome, the pain, send them to radiology, get them to orthopedics. They put rod in. They usually rod both hips, and it takes care of the problem. Okay, ONJ. Well, osteonecrosis of the jaw is incredibly rare. In low dose, people who are being treated for osteoporosis, about 1 in 10,000 patient years. So I've seen about 2 or 3 of these, and I have literally 1,000 people or more on osteoporosis medications. You can diagnose this with a cone beam CT or an MRI, and you can diagnose it early with those. The risk factors: poor oral hygiene, steroids, bisphosphonates, and particularly at high dose, we're using it in cancer. People who have gum disease, diabetes with gum disease. People who come into the office, you look in their mouth, and they have a bunch of loose teeth and some black teeth in the back. Those people should not be on bisphosphonate. Their risk is obviously higher. And you say, well, gosh, I don't know if I'd pick that up here. I don't know if I'd see that. But I'd sure see that when I look at someone's mouth. And in fact, that equals this. And so the MRI isn't going to miss. The cone beam CT isn't going to miss. Whatever radiologic procedure you get isn't going to miss the osteonecrosis of the jaw. So if you're worried, just get a CT. Okay. It's not the duration of therapy, it's the risk factors. As we said, good oral hygiene is your best protection from osteonecrosis of the jaw. Go and see the dentist and correct the dental disease before you start the bisphosphonate. Also, if you're at high risk, there's some controversy about should I stop the bisphosphonate before my dental procedure? Excuse me, it's in the bone for 5 years. So, okay, Mrs. Schmedlap, you can have your crowns and implants. It's actually only implants. It's crowns, cleaning, extractions, no problem. You can stop it if you want till the socket heals. Implants are the problem, and you're more likely to get osteonecrosis of the jaw if you have infected gums before you have the implant. So you make sure your patients have decent dental health. You're not ever going to see this. Okay, when do we stop bisphosphonates? The data from the FlexFit extension study, which is the only real data we have, tells us that if your patient has never had a fracture, they had osteoporosis, or they were frax positive, and you put them on a bisphosphonate, but they'd never had a fracture, if they have osteoporosis still, you want to continue. If they don't have osteoporosis, you can stop. So if they've never had a fracture, but you put them on because they're osteoporotic or because the frax told you to, then you can stop when they're not osteoporotic and take a drug holiday. If they've had a prevalent fracture, and they've generalized this to any fracture, but in the FlexFit extension study, they were looking at vertebral fractures, and those are the most common. So if they've had a prevalent fracture, then if you are no longer, if you're below or equal to -2.5, you're going to continue. If you're -2 to -2.5 T-score, you're going to continue. But if your T-score is above -2, then you can stop those people and take a drug holiday. So you're going to put them down a level. You're going to make sure that their T-score is -2 or better. I usually make sure it's better than -2. I want to see a 1 before that T-score. So -1 point anything, you can really stop these folks. And the drug holiday in general is about 2 years. The newer guidelines are essentially the same. But they say no fragility fracture. They're generalized into any fragility fracture. No fragility fracture before or during therapy. If they don't have osteoporosis, consider a drug holiday. Again, if you had a fracture before or during therapy, you can continue for up to 10 years with your bisphosphonate, or you can switch over. Most of us are switching over to either denosumab or a bone stimulator. You reassess every 2 to 3 years during this time. You take a look, and if there's a fragility fracture on therapy, you say, well, you know, how long am I going to treat here? Well, if you've had a fragility fracture, I probably ought to treat you for up to 5 years. If you've had a fragility fracture while you're on therapy, I'm going to treat you for 5 years. I'm going to change the therapy when you have the fracture. So Mary Jo falls down off the curb, fractures a hip while she is on alendronate. You're going to say, okay, I'm going to treat this lady for 5 more years, and I'm going to do it with something else. I'm going to switch to a bone stimulator. I'm going to switch to denosumab. Okay, when is the holiday over? When the patient begins to lose bone. You're taking the holiday because they have a chance of having bone suppression. So you're going to stop when the bone isn't suppressed anymore. And when is that? When you begin to lose bone. So it's pretty simple. When the holiday ends is when you have a significant decrease in bone mineral density. That is generally 3 to 5 years. I mean, these can last for a long time unless the patient, for example, takes steroids, unless they have vitamin D deficiency, unless something that happens that's going to increase their bone destruction. So usually people get about at least 2 years, if not 3 years. Now, how are you going to tell? You're going to get the bone mineral density in 2 years. Or you could get bone destruction markers. And NTX is the cheapest one. It is a very good marker. And if the patient comes out of the premenopausal range, remember that the bisphosphonates lower these bone markers to the premenopausal range. They really shut them down. As a matter of fact, some of the more potent ones lower them even below the premenopausal range. When the patient's bone marker comes back above the premenopausal range, then you want to start their medication again. Okay, we'll take a look in the last few minutes at the less commonly used medications. The denosumab or Prolia, indication postmenopausal osteoporosis with a high risk of fracture. Why is it not the first-line drug? In some cases it is, but why is it not? It has more side effects. More people get a rash. So the rash is the most common side effect with the denosumab, and it can be a very significant rash. It's easy to use. It's 60 milligrams sub-Q, comes in a pre-filled syringe, and the big thing to note about this is that you can use it in renal insufficiency right down to stage 5. So it is helpful. We know that it increases bone mineral density in stage 4 and 5 renal disease. We don't know that it prevents fractures. The data just isn't there, but again, lack of data doesn't mean lack of efficacy, and most of us use it in stage 3B, 4, and 5 for sure. You can use it, obviously, in a person who doesn't have renal disease as well. The big thing to remember about denosumab is that you must take your calcium. If you don't, it very, very effectively lowers calcium. And I use it in hypercalcemia malignancy, so, as do many people. So again, must take your calcium or you will become hypocalcemic. It doesn't allow you to mobilize calcium from the bone easily. So again, take your calcium, particularly if you have stage 3 or 4 renal disease. It's one of the most common causes of hypocalcemia in that group of patients. You need to monitor the calcium, the phosphorus, and the magnesium, and it works very nicely. Side effects, again, we said skin rashes, basically. You don't want to use it in people who have atopic eczema. You say, oh, Mrs. Jones, do you get a rash every time you change detergents? She says yes. Oh, it's probably not the drug for her. Psoriasis, plus minus, may get a little worse, may not. If they're on treatment for psoriasis with biological, no problem. You can still use the denosumab. You can get ONJ and bone pain and atraumatic fractures. Very, very, very unusual with this because it doesn't stay in the bone very long. Now, the other thing to remember is you can't stop this and just say, okay, we'll take a holiday, because it's only in the bone for 6 months. And at the end of 6 months, it's gone. And so at the end of 6 months, you begin to lose all the bone you accrued. Well, it's one side of the coin or the other. It either stays in the bone like bisphosphonates for a long time and can cause suppression, or the other things leave the bone and you lose bone. So you choose one or the other of these problems. And so what you need to do is you've got to keep these people coming every 6 months. You say, what do I get to the end? The T-score is -2, or they're fine. Should I keep treating them? What am I going to do? Well, you're going to use a bisphosphonate for about a year. That's expert opinion, and it's just come out from the Bone and Mineral Society. What do we do when we stop a bone stimulator? What do we do when we stop denosumab? We put the patient on a bisphosphonate. They've used alendronate in the studies with the bone stimulators, and you just use it for a year. So you kind of cement the bone you have in place, and they've shown that that works very nicely with bone stimulators. They haven't finished the study with denosumab yet, but it should work. Okay, let's take a look in the last few minutes at the bone stimulators. So teriparatide is the oldest one. It's been out for about 17 years. It's marketed as Forteo, and it's a direct stimulator of osteoblasts. And so it gives you more bone faster. The bisphosphonates give you in about a year or two, maybe 2 to 4% more bone. Teriparatide can give you about 6% bone increase during that same year. So again, they're more effective, but you lose the bone right away if you don't continue them or if you don't cement it in place with a bisphosphonate. It comes in a meter dose pen, decreases spinal and non-vertebral fracture. The study wasn't long enough to show decrease in hip fracture. It's approved for 2 years of use because there was osteosarcoma in some of the rats in the animal study. And so the FDA said to the Lilly Corporation that makes teriparatide, they said, you must show us for 15 years what the osteosarcoma rate is in the human who takes this drug. And in 15 years, there was no one who got osteosarcoma if they took this properly for 2 years. And so it's an incredibly expensive way to kill rats. Okay, so when to use it? Severe osteoporosis, T-scores of -3, multiple compression fractures. That's the person you ought to use it on. You can start at the beginning. You don't have to start a bisphosphonate. You can start this right away. The insurance company will actually even pay. Anybody who has fractures on bisphosphonates is unresponsive to bisphosphonates, or on bisphosphonates for too long. So 5 years, beginning to have bone suppression, maybe hit a fracture on bisphosphonate. This is a logical way to go. Has very few side effects. It's $1,100 a month. But again, most insurance companies pay a good chunk of that. And the charity program for all of these bone stimulators is very robust. So you can get them for your patient. Baloperitide is the other bone stimulator, just came out a couple of years ago, and it's the Forteo is a PTH analog, a piece of PTH 134. This is the 134RP. It's found in a number of tumors. They did not isolate this from tumors to give it to your patient. It's synthesized. It's an indicator for postmenopausal women with osteoporosis and a fracture. So you have to have a fragility fracture to get in on this one. And you need multiple risk factors for fracture, and you have to be failed or intolerant to available osteoporosis therapy. So it's, you know, down the line away in terms of usage. But it does work. And so what they did when they stopped it, they said, you're going to lose bone when you stop these. They started alendronate, and that was their initial FDA submission study. So you're supposed to use this for 2 years and then a year of alendronate. Side effects, both teriparatide and abaloperitide have the same side effects. They're almost the same drug. You say, why would they spend millions of dollars putting number 2 there on the market? It costs about half as much. So they're hoping to snag a big market share here. Same side effects, you can get hypercalcemia, so you have to monitor the calcium. You can get hypercalciuria, you can get renal stones from abaloperitide. Seldom happens, have to have good hydration, and watch for the symptoms. It's again limited to 2 years of use. There was not osteosarcoma in the rats in this study, but it was a carryover from the teriparatide, and the FDA had them put the black box warning on it. Okay, what's new? Well, as we finish up, you have to know something about the Wnt pathway. What the heck is that anyway? Well, Wnt pathway is ligands that are glycoproteins. It's a signaling pathway. And what happens is that the precursors of the osteoblast can go in different directions. And they can either become osteoblasts or they can become fat cells. Now, ladies, talk about just really annoying. In postmenopausal women, which way do you think they go? Not down the osteoblast. You get fat cells. I think that's really unfair. At any rate, how are we going to fix this? What happens is that sclerostin, which is present in high levels in most postmenopausal women, inhibits this pathway. So you don't get bone cells, you get fat cells. They said, aha, if we could block sclerostin, we could make an antibody to sclerostin, would the cells then go down the osteoblast route? You bet they do. And so what they did was to make an antibody, a monoclonal antibody to sclerostin, and that's romosozumab. And it enters the picture, it ties up the sclerostin, and what do you get? Osteoblasts. And what do you get for results? So it's an anabolic agent, and in addition to that, it decreases bone resorption, because sclerostin causes bone resorption, so it causes you to lose bone. So this antibody stops the bone loss from sclerostin, and it also increases the osteoblasts, so it works in both ways. It's the only thing we have that works in both ways. And again, you can use it for a year. It's given, it's interesting, it's 105 milligrams in a syringe, and it has to be 2 syringes. I don't know how they ever worked that out. And you give the 2 syringes the same day. Patient comes to your office, you go wham, wham, and that's it. And then you come back, and you do that every month for a year. It's only useful for a year. It's only approved for a year. And then you follow it with an anti-resorptive agent, or you're going to lose all the bone you gained. So it's just like the other bone stimulators and denosumab. Have to take an anti-resorptive agent for a year. Have to use alendronate. And it's indicated for women who have fragility fractures and are not able to tolerate other agents. So it is really down the line in your drug armamentarium. It's at the bottom. Well, actually, it's above calcitonin. How's about that? It gives you about 9 to 10% bone mass in 1 year. it's really quite an amazing drug, but unfortunately has a black box warning. It took 3 or 4 years to get through the FDA because the black box warning says should not be used in patients who have had an MI, a stroke, or a stroke in the last year, because it may increase the risk of myocardial infarction, stroke, and cardiovascular death. And we know that's true. So you have to select your patients carefully. But I have patients that are falling apart from their osteoporosis. I mean, they're going to die from just having fractures and the morbidities that go with that. And so those are the people where you're going to use Avinity, it's called Avinity, or romosozumab. Okay, in summary, look at the screening tool. You're going to look at the DEXA picture. You're going to get the T-score for diagnosis. You're going to look at the bone density change to tell you whether or not your patient is gaining or losing bone. To treat osteoporosis, if you have high-risk osteopenia, you're going to determine that with FRAX. Therapy for this, either high-risk osteopenia or osteoporosis, bisphosphonates, 3 to 5 years, safe window, safe drug. Don't be afraid to use these. And if you are afraid to use them, send the patient to someone who isn't, because we're losing ground in osteoporosis in the United States because we're not putting people on inexpensive bisphosphonates when they have a fragility fracture. Again, drug holidays, again, no fractures, T-score above -2.5 after 2 to 5 years. Stop fractures, T-score above -2 after 2 to 5 years. The bisphosphonate you can stop. Holidays over when you have a fracture or significant decrease in bone mineral density, or if your insurance company will pay for it when your NTX bone marker gets above the premenopausal range. And denosumab, you can use denosumab. Now they have 12 years of data that just came out. It works for 12 years. It doesn't cause bone suppression. It keeps decreasing fractures, and it keeps building bone mass, particularly hip bone mass, particularly cortical bone mass, for 12 years. So this is a long window of opportunity, but remember, you have to get the people in every 6 months, or they're going to lose bone, and they may fracture. Okay? Romosozumab, well, wow, it's finally here. It really is, as you look in your armamentarium basket, very, very potent, excellent pharmaceutical, but you have to watch out because it has been associated, not causally, but associated with an increase in cardiovascular death. So myocardial infarction and stroke.